So welcome back friends, we are now going on to discuss one of the important small topic, complications of esophagectomy and esophageal surgeries. This is one of the important topics. There are various complications, let me discuss one by one the interesting complications alone. The first important complication, very interesting, is Kylothorax. So you have now operated, esophagectomy has been done, either a transhiatal or transthoracic. Now the patient is having an ICD. So this is a operative mediastinum. So we have kept an ICD, intercostal drainage tube is there inside like this. So it's the second post-op day or a third post-op day. Usually we start the feeding. Through the feeding jejunostomy, we start the normal diet. So through feeding jejunostomy diet will be started. Initially the feeding, the ICD tube is showing you pink color fluid. Okay, initially there is a pinkish color fluid coming out in the ICD. So once I start feeding through feeding jejunostomy, I start the feeding, immediately this pinkish color fluid becomes milky white fluid, immediately becomes milky white fluid. So this is having a huge output, around 500 ml to 1000 ml is coming per day through the ICD, which is milkish white in color, which is nothing but a chylothorax. I am having a strong doubt this can be a chylothorax now. How will I confirm this milky white fluid is nothing but a chylothorax? It is by testing for the fluid analysis. The fluid will be analyzed. Fluid analysis will be done, and the fluid analysis shows increased triglyceride level. The triglyceride level will be increased, more than 110 milligrams per deciliter will be present. The triglyceride level will be elevated in this fluid. That is one of the diagnostic point to say this is a case of a chylothorax. Now chylothorax, now we have confirmed this is a chylothorax. This might have happened due to injury to the thoracic duct. Why it happens is because injury to thoracic duct has happened. While I am operating, I have injured the thoracic duct, and this thoracic duct injury has caused this chylothorax. So please remember, this is now given a classification in Shackelford, you should know, that is type 1 chylothorax. It is the chylothorax that is leaking chyle through the ICD tube, which is treated by just dietary modifications, Just with the dietary modification itself, the chylothorax has stopped further leak. So what is this dietary modification which is being made? So instead of giving high fat diet, we have to give medium chain triglycerides. You give medium chain triglycerides. So medium chain triglycerides or medium chain fatty acids are given. That is stopping the chyle leak. That is type 1. Type 1 is just treated by dietary modification. Type 2 is treated by immediately keeping the patient nil per oral, or totally all the enteral nutrition stopped. Enteral nutrition is stopped, and we have started on total parenteral nutrition. So total parenteral nutrition has stopped the chyle leak. That is type 2. So type 2 is further now divided into, in severity level, less than 1 liter or more than 1 liter. So this is a severity. Less than 1 liter per day or more than 1 liter per day are the two types of severity. There can be a less than 1 liter per day chyle leak or more than 1 liter per day chyle leak. In case if it is at more than 1 liter chyle leak, and immediately as I start nil per oral and enteral nutrition is stopped and I start the TPN, a chyle leak which is more than 1 liter per day has now stopped. Okay, has now stopped. It is known as type 2B. So the chyle leak which was very high initially, which is more than 1200 ml per day initially, has stopped now totally, has stopped completely and stopped, successfully treated by only TPN and nil per oral. This is known as type 2B. This question has come in NEET SS. So what is type 2B? Type 2B is a leak which is more than 1200 ml per day, that has stopped now. Immediately as I started the parenteral nutrition and nil per oral, it has stopped now. That is known as type 2. So type 3 is a condition which needs surgical or interventional therapy. Type 3 is not stopped by above treatment and needs interventional or surgical treatment. Interventional or surgical treatment is needed. So type 1 treated by dietary modification, type 2 by nil per oral and enteral nutrition, type 3 needs interventional and surgical treatment. These are the types of thoracic duct injuries. So the types of thoracic duct injuries are Treated by dietary modification is type 1. Treated by nil per oral and enteral nutrition is type 2. Type 3 needs interventional or surgical treatment. This is type 3. So these are the 3 types of chyle leak. I request you to please remember for your exams. Okay, please don't forget this thing. So now coming to the management of type 3 leaks, which are not controlled by means of medical treatment or by TPN, which is not controlled. What I am going to do? Interventional treatment. Interventional treatment. So please remember, while you are doing operation, if you are seeing a chyle leak, if it is a very small leak, so this is let us assume this is a thoracic duct, and you are seeing thoracic duct is leaking because of injury. At the operative time itself, you are finding a thoracic duct leak. Please immediately ligate it. It won't heal automatically. Please ligate it intra-op itself. Ligate it intra-op itself. Because it is not like a blood vessel. It will not clot. Chyle will not clot and it will leak only. So chyle does not clot. That is also an MCQ. Chyle not clots. So please ligate the vessel. Ligate the duct. When you see a leak, ligate the leak. If you have not ligated the leak only, that is going to cause a post-operative chylothorax, and we have to do enormous procedures. So procedure number 1. So this is a cisterna chyli. This is thoracic duct. This is seen between azygous vein. This is azygous vein. This is aorta. And posteriorly, what is present? Posteriorly, we have vertebra. Posteriorly, we have vertebra. So now, this is a xiphisternal area. This is xiphisternal area. So now, what I am going to do, in a patient who is having a continuous chyle leak, I am going to do a NMAS ligation. Please remember, NMAS ligation. NMAS ligation is done between azygous vein, aorta and vertebra. Between these 3, I have to put an NMAS ligation here. I have to put a NMAS ligation here. This, where will you do NMAS ligation? It is between azygous vein on right side, aorta on left side, vertebra posteriorly in the xiphisternal area or in the lower part of the xiphisternum. We have to ligate it. Please don't forget this. This is the place where you do NMAS ligation of the thoracic duct. One more place also we can do. That is going here. The thoracic duct is now going here and it is entering here at the junction of subclavian vein and internal jugular vein junction. It is entering here. Now I am going to ligate it at one triangle here known as Poirius triangle. Poirius triangle is bounded by left subclavian artery. Okay, it is bounded by left subclavian artery. So this is arch of aorta, and here also there is vertebra posteriorly. So this is a triangle. I am not drawing it perfectly, but it is a triangle of Poirius is bounded by left subclavian artery, arch of aorta and vertebra. This is an expected MCQ. Please don't forget what is Poirius triangle. This is one another place I will ligate the thoracic duct. So thoracic duct may be ligated at 2 places, one at Poirius triangle and another at the lower part of the thing. Okay, so please don't forget this chylothorax related issue. So chylothorax is a high yield MCQ for your exams. One of the complications of esophagectomy is chylothorax. This chylothorax per se, it is a morbidity only. It increases morbidity but not increases mortality. Please remember, it just only increases the morbidity and not increases mortality. So nothing to worry. Just we have to do, it is causing morbidity, extra admission and extra cost for the patient. So these are the complications with chylothorax, but there is no increased mortality seen with chylothorax. So chylothorax, please don't forget, these are the essential points for your exam. So one of the I am discussing the complications of esophagectomy. So please don't forget the various complications. What are the other complications? So organ damages. What are the organ damages which can happen apart from this? Organ damages which can happen during operation are, number 1, recurrent laryngeal nerve injury can happen and the patients can go for vocal cord paralysis. According to Shackelford, this is more common with transthoracic esophagectomy. It is more common than transhiatal esophagectomy. Recurrent laryngeal nerve injury is more common with transthoracic esophagectomy. It is around 7% of the cases can develop vocal cord paralysis in transthoracic esophagectomy. It is more common than in transhiatal, number 1. So number 2, one of the very important complications is atrial arrhythmia. Atrial arrhythmia is one of the most dangerous intra-op complication. Is most dangerous intra-op complication when we are doing a transhiatal. The heart can go for atrial arrhythmia is most dangerous intra-op complication. And all sort of pulmonary complications, all whatever you want you can put, pulmonary atelectasis, lung abscess, everything. Pulmonary complications are one of the most common cause of mortality. Most common cause of mortality is pulmonary complications. So the patient develop more of pulmonary complication and causes more chances of death. Pulmonary complications are there. And even patients can develop pancreatitis by injuring the pancreatic capsule. We can even induce pancreatitis during the surgery. During the surgery, this can happen. So it is very common. It is due to injury to the pancreatic tail or body during ligating of short gastric vessels. During short gastric artery ligation, this can happen. Injury to the pancreas can happen. So these are some of the important complications, and one very rare complication which can happen after esophagectomy. Already I told you, that is a paraplegia. Paraplegia which can happen, which is due to injury to artery of what I told you, artery of Adam-Kiewicz. It is nothing but a branch from posterior intercostal artery. It is a branch of posterior intercostal artery. Paraplegia can happen due to injury to artery of Adam-Kiewicz. So one another interesting complication is aortoesophageal fistula. So actually this is more common with aortic aneurysm repair rather than esophageal surgery. It is more common with aortic aneurysm repair than with esophageal surgery. But please don't forget, aortoesophageal fistula. Aortoesophageal fistula will present with a triad known as Chiari triad. What is this Chiari triad known as? Chiari triad is known as mid-thoracic pain. The patients will present to you with a mid-thoracic pain. Patient has mid-thoracic pain, number 1. Sentinel arterial bleed, number 2. Patients may have sentinel arterial bleed, number 2. Number 3, following that sentinel arterial bleed, the patient can have exsanguinating hemorrhage. Exsanguinating hemorrhage also can happen. So Chiari triad is characterized by mid-thoracic pain, sentinel artery bleed, and exsanguinating hemorrhage are the features of aortoesophageal fistula. Mid-thoracic pain, sentinel artery bleed, and exsanguinating hemorrhage can happen in aortoesophageal fistula. It has high mortality, immediate surgery needed. Please remember, immediate surgery needed. Unless you do an emergency thoracotomy and catch the bleeding point, it will cause sure death. Sure death is seen in these cases. So please don't forget, this is aortoesophageal fistula. So these are all, though many list of complications, they will not have much of MCQs. MCQs are more common from the one complication which is known as anastomotic leak. Anastomotic leak. The Achilles heel of this operation is anastomosis. The Achilles heel of the esophagectomy operation is anastomosis. If it is going to leak, it is going to cause enormous complications. So anastomotic leak is one of the most dangerous complication, and some books very clearly says anastomotic leak as the most common cause of mortality in esophagectomy. So there is a controversy. So anastomotic leak is one of the important, most common causes of death in case of transthoracic esophagectomies, not in transhiatal. Transhiatal, the leak will come out and it will not cause death. But in case of transthoracic esophagectomies, anastomotic leak is one of the cause of death, common causes of death. And there is a classification. What is this anastomotic leak first? So this is esophagus. This is a gastric conduit we are bringing. So this is esophagogastric anastomosis. This can be there in the cervical region. If it is a transhiatal esophagectomy, we do it here. It can be there in the cervical region, or it can be there in the thoracic region. So thoracic leak is more dangerous because it causes mediastinitis and high mortality seen. Please remember, it causes high mortality seen with those cases. So mediastinitis can cause and high mortality can happen in anastomotic leak. This is most important point I want you to tell. So please don't forget, mediastinitis and high mortality is seen with anastomotic leaks. That is most important thing. Whereas cervical is having less mortality because the collection we are going to let it out. So less mortality is seen in cervical anastomosis. So this anastomosis are done by various techniques. Let me show you various techniques we are doing. So this is esophagus, cervical esophagus. This is the gastric conduit I am bringing out. So this can be anastomosed by direct hand suven. single layer or two layer, both can be done. Single layer Hand-Sewn or double layer Hand-Sewn can be done. So this is Hand-Sewn anastomosis. So nobody is nowadays doing Hand-Sewn anastomosis. Most of them are using only staple. But please remember, this is a Hand-Sewn anastomosis, which the two conduits will be anastomosed end to end. End to end can do the anastomosis like this. It can be done either end to end or end to side also can be done. So that is anyhow Hand-Sewn anastomosis using a 2-0 vicryl or a 3-0 vicryl. We do this anastomosis. Coming to the stapled techniques. Stapled anastomosis. We have two types of stapling. One is circular stapler anastomosis and another is partial mechanical stapled. Partial mechanical stapled. What is this circular anastomosis? Please remember, this is cervical esophagus. This is a gastric conduit. I will pass the circular stapler through this place. I will pass the circular stapler through this place and I will keep the anvil here and I will do a end-to-end anastomosis. I will do a end-to-end anastomosis with a circular stapler. This is circular stapled anastomosis. Partial mechanical, see what I am doing. This is the cervical esophagus and this is the gastric conduit which is pulled up. Now I am going to use a linear stapler like this. I will use a linear stapler like this and I will do a posterior stapled anastomosis. You can see I am going to staple this. It is going to become a posterior stapled anastomosis like this. So here the anastomosis is done. So the anteriorly there is an opening now. So this area is stapled like this now. So there is an anterior opening. That anterior opening I will do a Hand-Sewn like this. So this is partial mechanical. That is nothing but posterior stapled and anterior Hand-Sewn. So this is mentioned as end to side or side to side. It can be either end to side or side to side, but anyhow it is a partially mechanical stapled anastomosis. Partially mechanical. Okay, this is partially mechanical. End to side or side to side anastomosis done. This is stapled anastomosis. So these are the various techniques of anastomosis. And after all these techniques, we have to be very, very aware about the leaks which can happen. So for the leak classification is there, that is known as Lee-Root classification. Please don't forget, that is known as Lee-Root classification of leaks. The classification given in your books is Lee-Root classification of anastomosis. So what is this Lee-Root classification? So Lee-Root classification is clearly showing you 4 grades. There are 4 grades of Lee-Root classification. Grades are grade 1, grade 2, grade 3, grade 4. There are 4 grades of Lee-Root classification. So grade 1 is a radiologically diagnosed. Patient is not having any symptom at all. No clinical signs are there. We usually do a contrast study. That contrast study shows this leak. That is known as grade 1. So no change in treatment, no change in management. Just continue the same treatment. Change in management is needed. So no change in management needed for grade 1 radiological leak. So grade 2 is a minor, clinical minor. What is the findings in clinical minor? The patient will tell, sir, I am having pain and inflammation in the cervical esophageal anastomosis area. There will be clinically inflammation will be present. When you go and examine the cervical esophagus, there will be inflammation will be present. And X-ray when you take with the contrast, that will show you contained leak. Or if it is the chest, there will be a contained leak. Patient may have fever, WBC count increased, and there may be a contained leak seen. Contained leak is present. So these are the findings in grade 2. So they have to, immediately we have to open it and drain the wound. Drain the wound. So drain the wound and keep the patient, delay the oral intake. Delay the oral intake of the patients. So drain the wound and delay oral intake is clinical minor. Delay the wound and drain the wound and delay the oral intake is minor, and we have to give them antibiotics. Antibiotics are given. So this is for clinical minor. Coming to clinical major, the patient is very, very sick in this case. So clinical major, the patient is very sick. What is happening here is patient is again having fever, severe WBC count increase. WBC count is increased. There is so much of toxicity. Patient is having disruption of the anastomosis. Disruption of anastomosis seen. So disruption of anastomosis in the wound has opened up now. So we have to do immediate drainage by means of help of radiologist. So if it is a cervical wound, we can drain it by opening it. Nothing to worry. Cervical wound, we can open it. But if it is a mediastinal leak like this, we have to use CT guided drainage. The help of interventional radiologist, we have to do a CT guided drainage. The last one is more dangerous. The conduit has gone for necrosis. No use at all hereafter. Conduit necrosis means the conduit has gone for black color because it is a type of anastomotic leak. Even if the anastomosis is normal, the conduit has gone for black color means it is gone. Patient is in severe sepsis. In severe sepsis, and it is endoscopy shows gangrenous conduit. No other go. We have to reopen and we have to remove it. Remove the conduit. That is the treatment for this case. So remove the conduit. No other way. So there are 4 grades of Lee root classification. 1 is radiological, 2 is clinical minor, 3 is clinical major, 4 is conduit necrosis. So please don't forget these things. Okay. So these leaks are all because of what reason? What is the reason for the leaks? You tell me. So what are the points you should remember while I am doing the anastomosis? Points to be remembered. While I am bringing this anastomosis, I told you this is a Achilles heel is this. Achilles heel of this operation is anastomosis. So what are the points I should remember? There should be adequate perfusion to the conduit. Adequate perfusion should be present to the blood supply present to the conduit. There should be adequate blood flow to the conduit. Number 1. There should be minimal tension to the collateral vessels. So there may be collaterals. So those collaterals should be not disturbed to collateral vessels, and there should not be any tension in the anastomosis. There should not be compression or pressure. Something should not be there. Tension should be less. Tension-free anastomosis should be there, and it should be distance should not be very long travel. The conduit, as you travel more and more long distance, the conduit can become ischemic. The distance traveled is kept as minimum as possible. So what are the points to be remembered? Adequate perfusion should be present to the conduit. Minimal tension should be there on the collaterals. Patient should have tension-free anastomosis, and distance traveled is kept as minimum as possible. So this is very important because anastomotic leak is going to cause 3-fold increased risk of death. It is going to cause 3-fold increased risk. 3-fold increased risk of death is seen with anastomosis. So 3-fold increased risk of death is seen, and incidence of this anastomotic leak ranges from 0 to 35%. Different surgeons have different rate. It ranges from 0 to 35. And please don't forget this Lee root classification of anastomotic leak. Very important exam question. Lee root classification is for anastomotic leak in which conduit necrosis is coming under grade 4. Conduit coming under 4. So now what are the factors to be remembered in case of anastomosis? Be remembered. So this high yield MCQ definite exam question for you. What I am going to tell you now. What are the factors to be remembered in anastomotic techniques? Number 1. Who will have more leak, who will have less leak is depend upon the site of anastomosis. Which site of anastomosis will have more leak? Cervical anastomosis have increased anastomotic leak. Mediastinal anastomosis have decreased anastomotic leak. Mediastinal has decreased anastomotic leak. So please remember this. So but cervical anastomosis leak is less dangerous. Mediastinal leak is more dangerous. This is the first point I want to tell you. So the more and more distance the conduit is going to travel, there is more chances of leak. Second important thing regarding the type of anastomosis. I told you various techniques, type of anastomosis techniques. Based on that, there is no difference in leak rate. Very important point. No difference in leak rate. There is no difference in leak rate with Hansuvan versus Stapler. Both these guys have the same percentage of leak rate. But there is one more complication which you should remember in anastomosis. That is anastomotic stricture. Anastomotic area will go for stricture, though it is not a major issue to worry. You can easily manage them. Anastomotic stricture is not a major issue to be worried. But it is also a complication. Anastomotic stricture is also a complication. It is more common with double layer hand-sewn anastomosis. More common with double layer hand-sewn anastomosis, followed by circular stapler anastomosis. Least common with partially mechanical stapled anastomosis. Partially mechanical stapled anastomosis has the least common stricture. So, hand-sewn anastomotic techniques, based on the anastomotic techniques, we have various incidents of anastomotic stricture. It is more common with double layer technique. So, more common with hand-sewn double layer technique has more common. Among the two staplers, circular stapler technique has more common stricture because it is only a circular anastomosis here. Whereas in a partially stapled, you can practically understand I am doing a wide anastomosis with a linear stapler. That is the reason. So, anastomotic staple technique, that point I want you to remember in this thing. Okay. So, then comes the third point in this. We have to know the root of anastomosis. We have to know about the roots of anastomosis. Does it have any difference? So, roots of anastomosis, I told you there are many roots: posterior mediastinal root, substernal root, subcutaneous root. But the interesting point is there is no difference in anastomotic leakage with related to roots. No difference in leak rates related to roots. Roots of drainage, there is no difference in leak rates. There is no difference in leak rates based on this roots of drainage. There is no difference in leak rate. That is the third point I want to tell you. So, though there is an extra travel with subcutaneous root than substernal root, gross studies have shown there is no difference in leak rates because of the mediastinal roots. So, we have to assess the microcirculation, because microcirculation decides the conduit whether it will leak or not. So, microcirculation is assessed by looking for, number one, we look for graft color. Number two, we look for temperature of the conduit. So, number three, we look for Doppler signals. We use Doppler signals also. But the best among all to look for the microcirculation is the fourth one, which I am going to tell you, intraoperative. This is the best to assess the conduit blood flow. Intraoperative laser assisted fluorescent dye angiography. Fluorescent dye angiography is the best among all the things. Okay. Intraoperative laser assisted fluorescent dye angiography is the best to assess the microcirculation. Please remember this fourth point. Fifth point is very interesting point, though it is not proven to be beneficial in humans. It has been found beneficial in animal models. What is this? Ischemic preconditioning. Ischemic preconditioning. So, you all know very well the conduit of stomach is going to survive only based on which artery? It is based on right gastroepiploic artery. So, what I am going to do, 2 weeks before the surgery itself, I am going to put a embolization of left gastric artery, left gastroepiploic artery and right gastric artery. All these arteries I will do angioembolization with the help of a radiologist. So, therefore, what happens in the next 2 weeks after I have embolized, this collaterals will develop very well and the conduit will be having an extensive vascularity. So, I am going to bring the conduit which is going to have an extensive vascularity. But this is found beneficial in animal models, so far not in human models. Ischemic preconditioning is beneficial in animal models. So, it is not yet proven in humans, not much effective as in animal models in humans, not effective in humans. Okay, this is one interesting point, ischemic preconditioning before the anastomosis. And sixth point, you all know very well, in a case of substernal root, you can see in a substernal root, the conduit has to come out of this clavicular compression out. There is a compression happening on the conduit. It can cause venous obstruction and conduit necrosis. So, what I can do? I can divide the interclavicular ligament. I will divide the interclavicular ligament to avoid venous compression. It is beneficial. It is found to be beneficial. Especially in a substernal root, this is found to be beneficial. All substernal root, my professor Chandramohan sir used to cut all the time the clavicular ligament, and he used to dismantle the clavicle. It will be like a floating clavicle after the surgery so that it won't compress the conduit. So it is especially done in substernal route. So very important reason for gastric conduit going for avascularization in the postoperative period is postoperative gastric distension. Please don't forget, postoperative gastric distension is one of the important causes of this. Postoperative gastric distension is one of the important causes of venous drainage inhibition happens. Therefore, I should always put a Ryle's tube. What are the things I will do? Ryle's tube decompression will be done by me. Very important thing. So to avoid the thing, I will do Ryle's tube decompression. Some people always do pyloromyotomy or pyloroplasty, that is going to decompress the stomach. Pyloroplasty or myotomy, pyloromyotomy, that is going to have some benefit. Or we should use pro-motility agents. Pro-motility agents are given, and number 4 we can give prostaglandin 1 analog. That is also having some benefit. So these are the things which can decrease the venous drainage. Venous drainage is decreased by the gastric distension. We can avoid it by putting a Ryle's tube, by putting a pyloroplasty, pro-motility agents, or prostaglandin 1 analog. So what is the gold standard to diagnose the anastomotic leak? So I have done an anastomosis. I have to diagnose the anastomotic leak. Now the answer is CT scan with less than 4 weeks patient. We give gastrographin contrast. Less than 4 weeks we should give a gastrographin contrast. More than 4 weeks I should give a barium contrast. This is one of the important MCQ for your exams. Gold standard to diagnose the leak is by means of CT scan. Can I do an endoscopy? Yes, you are always accepted to do an endoscopy. If you suspect a conduit necrosis, we can do endoscopy of a conduit. Endoscopy grading of anastomotic ischemia is there in book. It is there in Shackelford. You may get in exam. Anastomotic ischemia grading is available in Shackelford. You can get it. Number 1 grade. It is nothing but dusky blue colored mucosa near anastomosis. This is anastomosis. There is a dusky blue colored mucosa. So there is a dusky blue mucosa with a metal appearing mucus, like a metal colored mucus. Because of minimal leak, there is a metallic colored mucus seen, that is grade 1 leak. So partial anastomotic disruption, for example, this is anastomosis, there is a partial disruption seen, partial anastomotic disruption is grade 2. You can see partially disrupted, but there is pink mucosa seen. Partially disrupted, that there is pink mucosa present. So first one, blue mucosa with the mucus discharge present. Here it is a pink mucosal margins are there. So grade 3, complete breakdown. You can see this is a esophagus, this is stomach. It is completely disrupted. It is complete disruption seen. There is complete disruption, but anyhow, even with complete disruption, you can see some pinkish mucosa. You can see pink mucosa seen. So in 2 and 3, the mucosa is pink, means the blood supply is good. Even now the blood supply is good. So grade 4 is a guy who is having a black mucosa, disrupted anastomosis with a black mucosa, means that conduit has gone for necrosis. Black mucosa, it is also known as black esophagus. The conduit has gone for necrosis and it is no more useful. The even interesting point is sometimes the anastomosis may also be integrated. The conduit may also be integrated, but there is black mucosa completely seen. So black mucosa, the word comes, you should go for 4. The anastomotic breakdown may also be, may not be there. The anastomotic may be continuous, maybe there also be there. But anastomotic mucosa, the black mucosa is a feature of grade 4. So grade 1, dusky blue mucosa, grade 2, pink mucosa, grade 3, pink mucosa. 2 is partial disruption, 4 is complete disruption, 4 is black mucosa with a complete anastomosis will be normal also. This is known as grade 4. Please don't forget, these are the points I want to tell you from anastomotic leaks and related complications. Very important topic for your exams. Let me show you the images now from this topic so that it will be useful for you to understand this. And let me show you some MCQs also. So regarding the Kylothorax, false statement is incidence is 2%. It is true. Diagnosis made by measuring triglyceride level is true. It is Diagnosed during surgery should be dealt with suture ligation. I told you once you diagnose during surgery, immediately ligate it. Chyle usually clots and small leaks heal spontaneously is wrong. It will not clot. Please remember, it will not clot. So this is a chyle, milky white fluid coming out in the ICD tube after oral feeding started. This is a chylothorax. Where will you ligate the chylothorax? Please don't forget. And also don't forget the porous triangle, junction between arch of aorta, left subclavian artery and the vertebra posteriorly. So this is a place where I will ligate it. This is a porous triangle where we will ligate. So thoracic duct enters at the level of T12 vertebra and it turns towards the left side at T5 to T6 and incidence of injury is 1 to 2%. So please remember, it crosses from right side to left side at T5, T6 vertebra and it enters the left subclavian vein. Incidence is 1 to 2%. So type 1 only dietary modification, type 2 TPN, type 3 interventional treatment. I told you type 2B is what? More than 1200 ml per day now successfully treated by stopping enteral feeds and initiating TPN is known as type 2B. The following are the complications of esophagectomy. I told you: chylothorax, recurrent laryngeal nerve palsy, pancreatitis, atrial dysrhythmia, all the above. Answer is all the above. So these are the points I discussed. Chiari stride is described for aortoesophageal fistula. Please don't forget there will be mid-thoracic pain, sentinel hemorrhage and exsanguination after symptom-free interval. After some time, there will be massive hemorrhage which will happen. So the management, we have to immediately treat them by surgery. Immediate surgery is needed. Survival is now possible only with rapid surgical intervention. Otherwise, very difficult to save them. Leroot classification is for anastomotic leak. Conduit necrosis is type 4 Leroot. Please remember, it is type 4 Leroot. Okay, it is anastomotic leak. So this is a Leroot classification. 1 is radiological, 2 is minor, 3 is major, 4 is conduit necrosis. So now answer this question. Regarding the cervical esophageal anastomosis, false statement is: cervical esophageal anastomosis develops more leak than a mediastinal anastomosis. No doubt it is true. Ischemic preconditioning of stomach results in less leak rate. Yes, according to animal models, it is true. Let us keep it true. Circular stapler causes more stricture than Hansuan. That is, if it is a double layer Hansuan, it is going to cause more stricture. But if it is single layer, if that case is circular stapler is more common. Okay, circular stapler versus single layer Hansuan, circular stapler is causing more stricture rate. Double layer Hansuan has more stricture rate than circular stapler. Let us consider this is true. Pyloromyotomy has no impact on anastomotic leakage. It is wrong. I told you when I do pyloromyotomy, the venous drainage is good, so there is decreased anastomotic leak. Division of interclavicular ligament alleviates conduit venous obstruction is true. That is also true. So answer is D here. So all these points are very essential MCQ. This is a repeat question from JIPMER. So please be thorough with this question. This is a JIPMER question. Okay. So all the points I told you. Anastomotic leakage ranges from 0 to 35% and 3-fold increased risk of death. It is Achilles heel. We have to be knowing the site of anastomosis. Cervical anastomosis have increased leak, and depending upon the type of anastomosis, it is 48% in Hansuan, 35% in semi-mechanical. When you come to Hansuan double layer, it is double layer Hansuan, it is 45%. So double layer Hansuan versus circular stapler, Hansuan is more. Whereas single layer Hansuan versus circular stapler is more common to cause stricture. Okay. So roots of anastomosis, there is no difference in anastomotic leakage between various roots. And assess the functions, the best is to interop laser assisted fluorescent imaging. That is the best to assess the microcirculation. Preconditioning is good in animal model, not found in human model. So cutting the interclavicular ligament has better venous flow. So postoperative gastric distension can be minimized by Ryle's tube decompression, pro-motility agents, pyloromyotomy and prostaglandin E1 analogs. So please don't forget, these are the endoscopic grading of anastomotic leak for your exams. So this is very important for your exams. That's about the complications of esophageal surgeries. Thank you.